Picture this. You're having chest pains. You do the responsible thing and go to the emergency room. You sit in a waiting room for 2 hours, get seen by a doctor for maybe 20 minutes, have some blood drawn, get an EKG, and are told everything looks fine. Here's some aspirin. Try to stress less. You go home, relieved, crisis averted. Then 3 weeks later, an envelope arrives. And inside that envelope is a bill for $14,000. $14,000 for a 20-minute visit, for blood work that took a machine 30 seconds to process, for aspirin that costs 11 cents at Walgreens. And the worst part isn't the number. The worst part is that the number is completely made up. Not exaggerated, not marked up, made up, invented, pulled from a system so deliberately opaque, so thoroughly disconnected from any actual cost of care, that the hospital itself could not tell you with a straight face how they arrived at it. And if you have insurance, your insurer will negotiate it down, pay their portion, and send you a bill for the rest. And if you don't have insurance, you're on the hook for the full fictional number, unless you know how to fight it. This is American healthcare, and it is not broken. It is working exactly the way the people who designed it intended it to work. And by the end of this video, you are going to understand why your hospital bill looks the way it does, who is getting rich from it, and why nothing ever seems to change. Let's start with where the number on your bill actually comes from. Every hospital in America maintains something called a chargemaster. The chargemaster is the hospital's internal price list. It contains tens of thousands of individual line items, one for every conceivable procedure, medication, supply, and service the hospital might provide. And the prices on that list are not based on the actual cost of providing the service. They're not based on what other hospitals charge. They're not based on any external standard. They are, for the most part, whatever the hospital decided to write down. Studies have found that hospital charges average around 3.4 times the actual cost of care. In some categories, the markup is far higher. Medications administered in hospitals can be marked up 10, 20, even 100 times what the drug costs the hospital to acquire. That $800 IV bag of saline that went viral a few years ago. The saline itself costs about $1. The rest is chargemaster. And for decades, hospitals kept their chargemasters completely secret. You could not call before a procedure and ask what it would cost. It was one of the only industries in America where you could consume a product, have no idea what it cost until weeks later, and then be legally obligated to pay whatever arrived in the mail. The federal government eventually required hospitals to publish their prices online, starting in 2021. Hospitals technically complied. They published the data in formats so complicated, buried in spreadsheets with thousands of rows and cryptic billing codes, that the average patient still has essentially no ability to use it. Transparency was mandated. Actual transparency did not follow. But here's the thing about the chargemaster price. Almost nobody actually pays it, and that's where the system gets genuinely strange. When you have insurance, your insurer has a contracted rate with the hospital. The hospital bills $14,000. The insurer's contract says they only owe $4,000. The insurer pays their share. You pay your deductible or copay on the $4,000. The remaining $10,000 gets written off as a contractual adjustment that never existed as real money in the first place. So, why charge $14,000 if you're only going to collect $4,000? Because the chargemaster price is an anchor. The higher it is, the more leverage the hospital has when negotiating with insurers. Insurers negotiate discounts off the chargemaster, so a higher starting number means a higher landing number even after the discount is applied. Hospitals have every incentive to keep chargemaster prices as high as possible, not because anyone pays them, but because the fictional high number controls every real negotiation that follows. Economists call this price anchoring. The rest of us call it making up a number and working backwards. And the people who actually get handed the chargemaster price are uninsured patients. The most financially vulnerable people in the system receive the highest bill, the one designed not as a real price but as a negotiating weapon, and are told to pay it. Uninsured patients are charged more than anyone else in the building by a significant margin, for the simple reason that they have nobody to negotiate on their behalf. Now let's talk about the other players in this system, because the hospital is only one piece of a very large machine. When you go to a hospital, you may assume you're dealing with one entity. You're not. The hospital facility sends one bill. The physician who treated you may be employed by a separate physician group and will send an entirely separate bill. The anesthesiologist is often from yet another independent company with their own billing department. The radiologist who read your imaging, the pathologist who processed your labs, each of them a separate bill from a separate entity, arriving on a separate timeline. This is how a single emergency room visit generates 4 or 5 bills from 4 or 5 different companies, and how people end up going to an in-network hospital only to receive a surprise bill from an out-of-network anesthesiologist they never chose and never met. Congress passed the No Surprises Act in 2022 to address the most egregious cases of this, but the fragmented billing model is still very much the daily reality for most patients navigating the system. And then there's the elephant in the room that explains why prices keep climbing regardless of what regulations get passed. Consolidation. Over the last 2 decades, private equity firms and large hospital systems have been on a quiet buying spree, acquiring independent physician practices, urgent care centers, and community hospitals at a scale most people don't realize. Between 2012 and 2022, hospitals acquired thousands of independent physician practices. In many regions of the country, a single hospital system now controls the majority of available providers. And consolidation matters for one very specific reason. When a hospital system controls most of the providers in an area, insurers lose their negotiating leverage. Because if the insurer refuses to cover that hospital network, their customers lose access to most of the doctors and facilities in the region. So the insurer has to accept higher rates. And when the insurer pays higher rates, premiums go up. And when premiums go up, you pay more every month before you've ever stepped foot in a hospital. A study from the journal Health Affairs found that hospital prices in highly consolidated markets were on average 12% higher than in competitive markets. In some markets, the premium was significantly more. Consolidation doesn't just reduce competition. It systematically removes the downward pressure on prices that competition would otherwise provide. And once a hospital system owns the market, that leverage compounds over every contract negotiation for years. Let's talk about what happens when you actually get the bill, because this part matters. Hospital bills contain errors at a startling rate. Medical billing advocacy groups estimate that the majority of hospital bills contain at least one error, and that errors almost universally go in the hospital's favor. Duplicate charges, charges for services never rendered, incorrect billing codes that trigger higher reimbursements, and upcoding, which is the practice of billing for a more expensive version of a service than what was actually provided, are all documented and recurring problems in hospital billing departments. The reason errors persist is simple. Disputing a medical bill is exhausting, time-consuming, and requires a level of fluency in billing codes and medical terminology that most patients don't have. Hospitals know this. The path of least resistance for most people is to pay the bill or set up a payment plan and move on. And that calculation that most people won't fight it is quietly factored into the system. But here's what's worth knowing. Hospital bills are negotiable in a way that most people don't realize. Hospitals have financial assistance programs, often called charity care, that can dramatically reduce or eliminate bills for patients below certain income thresholds. Most hospitals are required to have these programs as a condition of their nonprofit tax status, a status that the majority of American hospitals hold, despite generating billions in revenue annually. These programs exist. They are not advertised. You have to ask. If you receive a bill that seems wrong or unaffordable, you can request an itemized statement and review every line. You can ask the hospital's billing department for a reduction. You can ask to be evaluated for financial assistance. You can hire a medical billing advocate who works on contingency to dispute the bill on your behalf. None of this is guaranteed to work, but the starting position of just paying whatever number arrives in the envelope is almost always the most expensive option available to you. The American healthcare system costs roughly twice what comparable developed countries spend per person, and produces health outcomes that rank near the bottom of that same group. Other countries have found ways to deliver quality care at a fraction of the price through a combination of price regulation, centralized negotiation, and systems that don't allow the chargemaster fiction to exist in the first place. The argument that American healthcare is expensive because it's the best in the world stopped holding up to scrutiny a long time ago. What American healthcare is the most expensive in the world, and that expense flows upward into hospital systems reporting billions in operating income, into pharmaceutical companies with profit margins that would make a tech CEO blush, and into an insurance industry that serves primarily as an expensive intermediary between patients and care. The system isn't broken. For the people at the top of it, it's working perfectly. The rest of us are just the ones getting the bill.